Thank you. Hello, everybody. Hopefully you've had some caffeine because it's 4 p.m. and we have to make sure that we give Nancy all our undivided attention. So on behalf of my colleagues, Susan Bartlett, and our co-director, Kaveri Dasgupta, we invite you and we welcome you to this inaugural Innovation and Methods Seminar. We have an impressive lineup of speakers. So we've got them and from all over the world. So please be tuned in on Wednesdays, on the first Wednesdays of each month. Okay, without further ado, I'm going to invite virtually our most impressive speaker, who's a professor at McGill, and she is an excellent communicator. She is a James McGill professor in the Department of Medicine and the School of Occupational and Physical Therapy. Some of you know her really well. She is none other than Dr. Nancy Mayo. So Dr. Mayo has had a very impressive career. She's a senior research scientist at the core. She leads a research program on function, disability, and quality of life for vulnerable populations. Her research focus has been measuring the health of populations at risk for disability. And she also contributes to evidence that works on policy. She specializes in trials of complex interventions, methods for analyzing complex outcomes, and measurement focusing on development of brief measures that incorporate the patient's voice, which is really important in today's world as it moves towards personalized medicine. She's a committed educator, also a life member of the International Society of the Quality of Life, and she supervised, you know, my jaws dropped when I read this, 120 students. My goodness. And 34 at the doctoral level. And she has, hold your breath, 300 lifetime publications. And she has presented her work at every continent. So we're so happy that she agreed to present. And very welcome, a very warm welcome to you, Nancy, and the podium is yours.
Well, thank you. Thank you very much for inviting me. I was sort of like, you know, shocked because I'm somebody who's always sort of around. I just sort of, you know, try to motor along in the background. And my real commitment is I absolutely adore teaching and supervising graduate students. And maybe that's why I've had a few of them. And all of my research has really been around the work of, you know, graduate students have contributed 100% to the work. So this is kind of another bit of a collective project. And I'm going to share my screen. I believe I can do that. Am I doing that? No. Okay, I'm making a mess here. All right, back to share screen.
Yeah, you should be able to pick up your screen with your PowerPoint on.
Yeah, here it is. Yeah, I always have to get the okay, where I don't see it. Am I seeing your screen or my screen? I'm seeing my screen. All right, let me go back, make sure it's on the screen. It was a minute ago. We tested it and then we lost it. Okay, here it is. It should be there. Share my screen. Where is my screen? No? All right, we'll go. I'm sharing my screen. It says I'm sharing it.
You are. There you go. There you go. So just go into presentation mode.
Perfect, yeah. Perfect. Technology works until you want it to. So when Nikki and Susan asked me to talk about something challenging and innovative and measures and methods, and I thought of a project that I'm currently struggling with. So it's not a work that's completely finished. It's a thinking of a very complex outcome, and it's really the story of trying to measure successful aging in people with HIV. And this is from the Positive Brain Health Now investigators, myself, Mary-Jose Bruyette, and Leslie Fellows. And we're a team of scientists that actually know nothing about HIV. And we got together to tackle the problem of brain health. And we were funded from CIHR to look at brain health in people with HIV because of the interesting, you know, from a scientific point of view, the link between virus and brain. And so we were very happy to be funded for 5 years and another 5 years to look at this. And so I wanted to tackle successful aging. And one of the challenges with complex outcomes is it requires a team. So not only did I do this with my co-investigators, but with our analysis team, Lynn Nadeau, who did most of the heavy lifting, Susan Scott, who's another one of our analyst statisticians, and then Nandini Dendakuri, of course, who helped us with some of the more complex analyses. But any of the errors are 100% mine if I say things that are a little off kilter. So one of the challenges I found in moving into an area that I don't work in, called HIV, I work in a lot of health conditions. I find that the health outcomes are more similar across illnesses than they are different. If you take a health outcomes approach, it doesn't really matter what you study. Everybody has the same needs, wants, desires. And what I found in working in the HIV community, that everything was talking about negativity. I heard all about the bad things. I heard about frailty and all these negative, horrible things. And I said to myself, why are we focusing on the negative? I come from the world of rehabilitation. We always think of the glass as half full rather than half empty. What can people do rather than what can't people do? And I found that less attention was paid to those doing well, thank you. And maybe we could learn a lot from those doing well in terms of how do we promote doing well as opposed to focusing always on the negative. So this has another terminology. And when you're looking at risk factors that are associated with bad outcomes, we call them risk factors. But factors associated with good outcomes are called promise factors. And what we also know is that they're not mirror images. Factors that predict risk of suboptimal outcomes are not necessarily the mirror image of factors that predict promise of optimal outcomes. You can't just flip the sign of the regression coefficient and say, oh, I think, therefore, absence of this will improve something. So I looked at the literature to say who's thought about this as these promise factors and these positive outcomes. Who's looked at this? So one of the challenges in looking at this literature is, what do you call it? What do you call doing well, thank you? So I started off by looking at aging well, and that got me nowhere because it's not actually the keyword or the mesh heading. So I had to use the term successful aging. If you want to look up the literature, you have to use the word successful aging. Otherwise, you get all sorts of odd things. So I've titled this talk Successful Aging so I can be found in PubMed. So in my exploration of this literature, I found that there were, in fact, 25 definitions of successful aging, which provided a range across HIV even, of 1 to 94%. So it's very precise, where, either nobody has it or everybody has it. So this is clearly not helpful. So on the right-hand side are some of the things that people put in definitions of successful aging. Avoidance of disease and disability. Good idea. How do you do that? Maintenance of high physical and cognitive function. Good idea. How do you do that? Sustained engagement in social and productive activities. Again, good idea. Action, not sure. So we could also have values on specific physiological parameters, and there's a list of about 500 things you could measure in the person's blood or whatever, other bodily fluids. And so you could use some conglomeration of that. You can do tests of physical capacity. Can you walk upstairs? Can you walk quickly? Can you bend and stoop? Can you get up from the floor? Can you squeeze something? All sorts of things. You can also ask the person, how are you doing? When you look at the practicalities of this portfolio, which, for example, the physiological parameters, which ones are we going to use? There's like many. Is the data available? Where do we get the data from? How do we interpret these complex melange of all sorts of different things? What's the clinical relevance of these conglomerations of items? What's actionable? Are any of these actionable? So one pivotal article that I thought was very interesting reviewed all these things and said, why don't we just ask the person? Well, wouldn't it be more practical to use, self-report? And they did mention that there's a huge library of validated, very well used and validated measures of health status and health-related quality of life, and that wouldn't they be something that would be a little bit more practical And of course, I'm somebody that works in health outcomes and is very interested in the patient's voice in measuring outcomes. So that was my natural affinity, was to look at self-report. So the other thing that this literature helped was to identify what these factors that other people have found that affect successful aging. So these are the portfolio, some biological factors. So if you're wearing your HIV hat, clearly there's lots of things related to virus and stuff like that. Lifestyle factors, cognitive factors, and resilience factors. And here's a definition of resilience factors. Those factors that give us the ability to thrive in the face of adversity. Those who are resilient are better able to move through the traumas of life. So clearly having HIV would be considered a bit of an adversity and produce some traumas in life. So they come out in the literature, as do, of course, personal factors and environmental factors. So now we have a model. You can see that we can start an exercise in data collection and also would lead to an analytical plan. So how do we apply successful aging to people with HIV? So this is a study, and I'm trying to write it up. Good luck with that when you see the end result. And one of the reasons that I suggested holding questions to the end is that it's a complex outcome. There's a path, and I think some of your questions will be answered in later steps. So the purpose of our study was to estimate the extent to which people aging with HIV meet criteria for successful aging and maintain this status over time. A second objective is to identify factors that place people at promise for continued successful aging. Seems fairly straightforward. So the data come from our Positive Brain Health Now cohort. It was people 35 years of age and older, 5 sites across Canada. They had study visits every 9 months, collected medical information. The focus is on brain health, so the focus was on cognition. So there's lots of cognitive questionnaires and, well, tests, cognitive testing. We had lots of questionnaires on every aspect of life. So we started with 856 people. We actually have 802 with complete data, which is pretty amazing. 84% are men, mean age was 53, 43% are working. It's just giving you a portrait of who we included. Duration of HIV was 17 years. You know, nadir, CD4 and things like that. This is not my area, but I will tell you that a low nadir CD4 count means a very poor immunological system, and such that 55% of our cohort at one time met criteria for AIDS, defining illness. Now, this group was largely diagnosed in the pre-heart era, and so they took a big hit on the immunological system, and they are living with the consequences of that now to brain health, because the virus does enter the brain. And so this is why we were funded for it, is because while, you know, earlier, the current cohorts are not going to live that, we still have to manage the current cohort. And also it does help with understanding complex outcomes. Our exclusion criteria were related, of course, to dementia and other neurological conditions and some other typical type things that you might exclude. But as an epidemiologist, I have to tell you who is not in the cohort. And when this cohort was theoretically continuous, consecutive recruitment from clinics, we can police that in our own sites, but good luck with that doing across Canada. You know, it's difficult to recruit clinically when it's not your study. And so I'm afraid there was a bit of cherry picking. But in our Montreal sites, or at least at the McGill site, we asked ethics for permission to ask people who did not want to enter our study why they did not want to be in our study. This is crucial to any cohort or observational study. If you don't know who you don't have, you might be able to do an association between X and Y, but you cannot deal with prevalence of anything. So we were the only site that granted ethics, and we published on that. Hopefully now you can cite our article if you ever want to convince your ethics committee to be able to query non-responders. We asked them, why did you not want to be in our study? And largely they said, we'd love to be in your study, but you know, I'm too busy, I'm working, I do a lot of traveling, my job is very demanding, Did these people have a brain health problem? No. And then because our study was on cognition, we asked, would you mind if we asked 2 questions about your cognition? So we asked 2 cognitive questions, and they don't have those symptoms. They had far fewer negative symptoms. So, you know, on the other hand, we wanted to study people with brain health challenges. So at least we got who we wanted to study. But when you're trying to come up with estimates of prevalence, the estimates of prevalence are biased because we have a more ill cohort. So just to underline that. So how are we going to measure successful aging? So one of the studies pointed out that there are self-report measures. Well, one of the most widely used measures of health status is the SF-36. It's a measure that comprises 8 subscales. It was developed to test the RAND health experiment, which was a study done in a long time ago. This is late 70s, I think, early 80s, in the States with the RAND Health Corporation, essentially testing fee-for-service versus global healthcare, but they had no outcome. They had no outcome for, you know, people coming in with, you know, hypertension, and people coming in with ear infections, and people coming in with abdominal pain. So they developed this measure, and they called it health status, and it measures these 8 things that you can read. And our idea was that, you know, these are not extraordinary things here that we're asking people to do. The highest level of physical function is vigorous activities, but these include things like, you know, household chores and, you know, standing up from a chair and walking upstairs and things like that. So the criteria that I thought made sense was to say, if you're successfully aging, you should be able to do all these things, but let's give you one that maybe you're not so good at. So I came up with the criteria, 7 or 8 of the 8 subscales at norm or more. Now we have Canadian norms on this measure, thanks to the CAMUS people who did a cross-Canada survey. So I was able to, for every single person, given their age and gender, I was able to find essentially a binary, and you know, there's issues with that, but whether they met norm or not. So this was the outcome, and now we had all of these variables that we were going to look at. So just to give you an idea, on these 8 subscales, this is the percentage of men and women who met norm. Well, you know, very low. In fact, most people did not meet the norms on these subscales. And I want you to put this in the context of the work I usually do on stroke and Parkinson's and multiple sclerosis and hip fracture. This group of people don't have these well-known disabilities, one side of their body being paralyzed or, you know, not being able to move. So I found this quite surprising that their health status, or their, it's now called health-related quality of life, was very, very low. Look at social function, vitality, pain, mental health, very low. This is the number of subscales, the proportion who met 0, 20% met 0 at norm, another at 1. When you get to my criteria, 14.2% met this criteria for successful aging, minus the stroke or the multiple sclerosis or the hip fracture. So this to me is a group of people with a lot of challenges. So if you look at our model, I now put a checkbox beside 7 or 8 subscales of I have a measure of successful aging. At least I convinced myself that this is a pretty good measure. So let's look at this side. Well, how am I doing on this side? Well, it's easy to measure personal factors. We have a database, a platform, we have a million things here. Biological factors, we have more biological factors than people. They measured absolutely everything, took thousands of pieces of blood, and you know, we have lots of that. We have lifestyle factors, we have cognitive factors. Oh, resilience. Well, we actually don't have resilience. So what did we do? So we had no measure of resilience in our database. However, there were 12 items that were similar to those included in a well-known resilience measure, the Connor-Davidson resilience measure, with 24 items. So we had 12 items. They weren't the same items, but they were close. And we needed a method to test whether the Brain Health Now resilience items could form a measure. We used rash analysis. We often say rash analysis to the rescue. That's likely to be a story for another day for those of you who are not familiar with modern measurement approaches, modern measurement theories. This is one of the modern ones that developed in the 1960s, just in case you think you're modern. You'll just have to trust us that this is a good way of testing whether items can be used as a measure. We found that 5 uncorrelated items fit a linear hierarchy in such a way that we could use it as a measure. These items are lonely, to what extent do you feel your life to be meaningful? Are you able to accept your bodily appearance? Are you interested in learning new things? Do you have plans and goals for the future? Lonely, you know about, it's part of this, it's not synonymous with social network because you can have a big social network and still be lonely. Meaning in life, meaningful life is a very important construct. Bodily appearance is really, self-esteem and acceptance. And these 2 items come from the motivation construct. They're from part of a motivation scale. So we have a measure of successful aging, and we have a measure of the items that have been shown in the literature to be important. When am I going to measure successful aging? Successful aging when? And when am I going to measure these promise factors? So our question was, is successful aging stable? So to answer that question, we did group-based trajectory analysis. I don't know whether you know any of these models. It's a probabilistic model that groups like with like. As your eye would do if you saw each person's plot of their data over time. Your eye would say, oh, these people look alike. I'm going to put these people together. Oh, these people look alike. It's a probabilistic latent model that says, let's, probabilistically assign people to groups. And the number of criteria met, 1 to 8, was our outcome. And this is the answer. So it's a wonderful methodology. We use it a lot. We actually use it descriptively. Before I use any longitudinal data, we run a trajectory analysis just to sort out what's going on and what would be the next model. I don't think you'd want to fit a mixed average model through this mess. Go ahead if you'd like. You get an average and it may not relate to one single person. So what happens here is that I want you to focus on the straight lines. So here's a line at the top, right at my criteria. There's a group of people who consistently over time met my 7, little under 7 outcome scales. And that was 20% of the population. This is a mess in here. We'll talk about that later. But group 4 only met 3, 1, and none. And these groups were another 20%, another 24%, and another 14%. The majority of people were flat. There were a few notable exceptions. This group started high. This group crashed slowly, 8%. This group crashed dramatically. One of the nice things about this approach is that we can look to see who got into this trajectory, very few people. And then we looked at their profiles and they got illnesses. Somebody had got cancer and somebody had a heart attack. So guess what? They crashed. So, but you can see these people and say, oh, there's only 1.2% of them. There was only 5 of them or something. So it was easy to find them out. And here's a group of people who are doing well, thank you. A small and actually getting a little bit better, but none of them changed into this category. So in fact, the binary grade 7 and 8 is stable over time. Some people moved in the 0 category, but my outcome here stayed stable over time. So when we run these latent class models, this latent trajectory model, you start with one trajectory and you say to yourself, does that fit the data? And then you start by adding increased numbers of trajectories. And because we had 4 time points, you can fit the intercept, the linear term, and the quadratic term. And so you keep going until you find the best number of trajectories that fit the data. Then you say, okay, now I say, can I get rid of the quadratic term? Do I have to have a curve? And now they're only straight lines with a linear slope. We check the fit. Can I remove the linear term? And if you can, then the trajectories are flat and you recheck the fit. So these are intercept only, and these are linear slope. And it's written up here. This is group 1 has no linear slope. It's intercept only, linear slope, intercept only, linear slope, intercept only, intercept only. So it's a very nice model. So now we have an idea that 80% show stable trajectories, and this group was stable over the entire time period. So good news is that I can now use my binary definition at where we have the most data, which is at the inaugural visit, and it's stable over time. So it's easy to model that outcome. It's a binary outcome, and it's rare, 14%. But what's the question? What are we trying to answer? And why it's taken me so long to write this paper is because the simple answer wasn't related to any question that I was particularly interested in. And I recalled the challenge of falling into the famous DIK trap, which is lots of data, little information, and no knowledge. So I had to go back and say to myself, what knowledge did we want to generate from this exercise in data massaging? For whom? And our answer to that was, we want to know how to get people to successful aging if they're not already there, and how to stay there if they are there. And we want this information for the people with HIV themselves and clinicians, but fundamentally for people with HIV who need to take charge of their lives. And, you know, society, and you'll see some of the risk factors, it'll be society that needs to step up to the plate here. So what are the options for this type of analysis? So I could certainly do logistic regression. That would be a logical thing. I got a binary outcome, but I got a million items. I got lots of them. So, you know, there's ways of dealing with a million items. We like to use what we call, I'm naming it after Robin Tamblyn. She used to use this, best of breed. You know, what are the best personal factors, best lifestyle, best cognition, best resilience? Can run a global model. I can do that. Can do structural equation modeling, because these variables are all, you know, at different parts of the developmental cycle. We've done a lot of structural equation modeling. It's not wonderful for binary outcomes, but, you know, it's possible. Or we can look at decision trees. So we started with option 1, and we looked at binary variables, and we looked to see what would happen if we just did, you know, ordinary logistic regression. Did a cross-sectional analysis. We have the rare outcome, 14%. We get odds ratios. Great. So I have a million answers. So if I'm looking at personal factors, we have, this is the odds ratio. The red ones were uninteresting. The green ones were relatively interesting. I'm trying not to use the word statistically significant. When we look at lifestyle factors, anything that's not red was interesting. Cognition, meaningful activities. This is physical activity. Meaningful, you know, engagement in society, physical activity. Alcohol, smoking, and BMI didn't do anything. Now we look at our resilience factors. Would you please note the odds ratio scale here is now 25. Lonely, stigma, meaning in life, not interesting. Optimistic, bodily appearance, feeling accepted, not much going on here. Self-management of symptoms. And then some more environmental factors. Now I've got an odds ratio here of 44. Informational support, money, physical environment. The red are not interesting. Feel safe in daily life, social network, having close friends. So this is kind of a typical approach. You got a binary outcome, you got 10,000 variables, you know, stick them in some soup, some regression soup. So I now know what variables are associated with successful aging. But is that what I wanted to know? I want to know about the variables. I don't care about variables. I don't treat variables. I want to know about the people. And there were no people in this analysis. So I felt that we had missed the boat by not really knowing who are the successful agers and who are not. So we decided to go to option 3 and do a decision tree and use recursive partitioning. Now, this is not a new animal. I learned this, I won't tell you what year I graduated from Epi School, but it was probably before most of you were born. Along me and Teresa, I think we went to the same school. And we learned this in the 80s. So this is not magic. This isn't like magic, stuff that was just invented yesterday. But what I've learned over the years about, wafting in and out of straddling the line between statistics and applied methods is that the statistics were developed for wonderful, perfect situations. And I get to apply them in really messy things where none of the assumptions hold and the variables are all measured with error and the errors are all correlated. And so you have to be very careful when you're doing this kind of analysis to get your explanatory variables perfect. You can't let the computer smush them around. You have to use data and theory to come up with the items. So after 17 awkward starts and a lot of help from Nandini, and Nandini always telling us, what are you trying to do? Because there's lots of techniques for doing recursive partitioning and these decision trees, but they are fit for different purposes. So borrowing from measurement, is it fit for purpose? So this is just a little picture here that our successful aging was driven by loneliness, safe in everyday life, and having a good social network quality. This first split, recursive partitioning wants to separate your data into the biggest extremes. And so on one extreme, we have 208, and the other extreme, we have 355. But I'm going to show you an ugly picture now, where it starts up. Don't forget, I've got 14.2% overall. Rarely lonely is 28. If I go to the other split, because I think I had it here. Seems to have come out. The other split is 4%. So if you look here, and the decision trees are very ugly to present. They look nice when you get them, but when you actually try and explain them to somebody, they're very difficult to present. So the first split was at lonely, 26%. In blue are terminal nodes. I self-pruned the tree. I didn't allow the program to do the pruning. I know more than a statistical program. I pruned it at terminal nodes less than 30 people, or obviously successful aging 0. So what I want to show you is how do you get to 0? So here's your rarely lonely, which is good. You're safe in daily life. Now you're 33% successful aging, and you have nobody to trust in. You're now 0. Here's another path. You've got somebody to trust in. Fear for the future, 9. You're safe. You're rarely lonely. You're not that safe in daily life. You feel threatened. No friends, you're 0. So here's smoking. There's a path there to get to 0 for smoking. Here's insufficient, 0. Life has no meaning, 0. So, but we're interested in the positive. We're interested in how do you get to these positive things. So I've summarized it here. We have 14%. The first split is 26-4. If you have the next positive factor, you're now 33% likely to be successful aging. Social network, 36. Fear of future, 40. No arthritis or lung disease, 48. Motivation, 60. Good social network quantity. Don't feel stigmatized and have money. You're doing pretty well. If you're on the poor side, the lonely side, one other factor gets you 0. So all you need, and this is 355 people on this side of the world here, and you can understand why my prevalence is 14%. At best, people who meet the first criteria of loneliness get up to 24% if they also feel safe and don't fear for the future and don't have lung disease and are motivated. So they have to work really hard to get even to this group of people. So I found this bit very helpful because I can now figure out who are the people. And just in case you wanted to go back to the logistic regression, I put the odds ratios here. So clearly they're compatible. They're going to come up with the same things. Only thing is here is motivation came out, and it didn't in the logistic regression. Smoking came out a little bit, and it didn't in the logistic regression. But, you know, we didn't test every single variable. So this was the variables that are associated in HIV with successful aging. They are largely determinants of health. Largely the role of society and social organizations to promote successful aging. It is not virus. It is not very much of anything, maybe arthritis or lung disease. Maybe pay attention to people that have some specific lung disease, particularly those that restrict activity. So largely determinants of health. So I now have some more boxes checked, right? I've got this outcome box checked. I've got these checked. What about cognition? Did I sort of, our studies on brain health, what happened to cognition? What were you thinking about in terms of cognition? So there's two ways of looking at cognition. You can ask the people, or you do a bunch of tests. So we developed specifically for this project, two measures. A measure called Communicating Cognitive Concerns. It's called C3Q, and I'm happy to say we finally got it published. After failing miserably at sending it to clinical journals, we just sent it to a methodological journal. It came back, no changes. So you want your paper published, or do you want to get clinicians to think differently? Forget it. I published it in a methodological journal, and it got accepted right away. So do a test, and these are performance tests, and we put them together again using rash analysis. Rash analysis was used here too. And we have a brief cognitive ability measure. This is a continuous score. This is a continuous score. So people with more indicators of successful aging had higher scores on the C3Q. Here's number of subscales at norm and above. Here's the mean of my cognitive measure, scored from 0 to 100. This is very nice. This circle here is our non-HIV norm sample. We had about study about 500 non-HIV, and they scored 80. But this line is the maximum, and this line says that it's not a sufficient condition. I've got people 100% cognitively reporting perfect cognition, and they have 0 subscales filled in, or 1 or 2. And nor is it necessary, because I've got people who are far below the norm and who are successfully aging. Thank you very much. So if this is self-report, when I go to measured cognition, there was no effect. Whether they passed or failed a cognitive test had nothing to do with whether they were successfully aging in this context. So cognition, measured cognition, is yet to be shown to be highly useful. So here we are with our checklist. I've got this, and I've got my outcome. So just to remind you what the outcome is, 7 or 8 subscales of the SF-36. I have to administer 36 items. I have to score them into the subscales. I have to link them to age and sex norms. Good luck with that. So this is a hopeless outcome. It's perfect for researchers like me who have programmers who just program the death out of these variables. It is not a useful outcome in any other sense of the word. So could we identify the most influential SF-36 items that discriminate successful agers? So guess what I did? I went back to my trees. So you see what happened is I repurposed these methodology to see if they could be useful other than figuring out if somebody is going to have a myocardial infarction. So I used the same methodology. And what I found was that successful aging, again, binary, was highly predicted by social function, good energy, good emotional support, and work. Good, not having work interference. And this is the table over here. So if you have good social functioning, instead of being 14%, you're 39%, 36%. If you have energy, you're now 56%. If you're not nervous, you have 72%. If you have a physical problem, no, now you've lost ground here. But If you have good mood, you're 85%. And if you're able to work despite having some challenges, you're 93%. If you have poor social function, you're practically zero likely to be a successful agent. What you probably don't know about these magic variables is that I just invented the SF6D. The SF6D is a utility measure that was developed from the SF36, and it has 6 dimensions. Now, granted, the 6 dimensions do have about 5 or 6 responses, but it's an awful lot easier to do that than the entire SF36. And this is what goes into the SF6D. Vigorous physical function, primarily vigorous activities, work, social, pain, downhearted, and blue. And you really only need to get 4 to be a successful agent. So guess what? I have check marks everywhere. So the conclusion to the study is that this is a complex outcome. It required complex methods, which I thought I was able to boil down to the tale of 2 trees. This is what we did. And I always like making methodological diagrams. And this is why it's called complex methods. So we started here, just to recap, we started here with successful aging. We identified using group-based trajectory modeling that it's stable over time. Got a check mark. We did logistic variables to screen, logistic regression to screen the variables for inclusion. We did rash analysis to identify uncorrelated resilience measures. We put them through a regression tree and we identified these animals here. So this was good. And then we went back here and then, well, we finished this story. We added cognition and we have an overall C statistic if I just stopped where I stopped my tree and didn't go down to 72 branches at close to 90, which is a very good prediction. We weren't satisfied with our successful aging. We did another regression tree to identify the most important SF36 items, and I ended up identifying the SF6D, which is a well-known utility measure. We went back, I didn't show you, but the SF6D itself is stable over time. So this study showed that 14% met our criteria of successful aging, which is kind of sad. But if we focus on people who are aging well and how we get those paths, it could be a more fruitful avenue to explore, not only to promote successful aging in HIV, but also to identify ways of preventing or arresting deterioration into frailty. And so the items are very important, and they're not that difficult to deal with. Social network, loneliness, stigma. Stigma is a societal fix. Meaning in life, getting people engaged early on, motivation, fear of the future, giving people hope that there may be not a cure, but I know there's a lot of work being done in different kinds of treatment regimens that might be very promising for people, even people aging with HIV. And of course, we had 1 million people in this study participating and funding us, research assistants, our co-investigators at the sites in Toronto and other sites in Montreal and Hamilton and Vancouver, and all of these other organizations that helped us. So thank you for listening, and there is lots of time for questions.
Thank you. Thank you, Nancy, for that brilliant presentation. The floor is open for questions. Please raise your hand or send us questions in the chat box. I have a question to ask you, Nancy. So successful aging as a concept has been applied before in other realms?
Yes, millions, yes. And each one has a different definition. There is a standard definition by Kahn and Rowe, which has been used, but essentially it's the avoidance of disability. Good luck with that. You know, the avoidance of disability, and it's that first one I gave. I mean, it's like apple pie. You know, don't get sick. You know, don't get disabled. So it isn't very kind of actionable. So, and again, you know, it wasn't me. It was one of the people who writes in Successful Aging said, why don't we just ask people? Why don't we use one of the well-known questionnaires, of which there are many, and use it? So I went, perfect, I have the SF36 on my data set. The other advantage, of course, many data sets have the SF36. It is one of the most widely used measure, and people pay lip service to PRO, so they stick in the SF36. So a lot of people will have it. A lot of HIV cohorts have it. Probably never analyzed it, but they have it.
So we have a question from Nandini. Did your strategy? So Nandini, you want to ask the question, or should I just repeat it? So Nandini asks you, did your strategy to learn from those who age successfully work given the many who were too busy to participate?
Right. So the issue is of course, I don't have data on them. I have no data on them. All I know is that if I wanted to estimate successful aging, I think the other 50% are probably doing well. So I may in fact have 64% successful aging, but I can only study who I have. I have no idea. I know with our negative outcomes, it's easier to do it with negative outcomes. And we've written on that. We've written a paper on selection bias, because guess what? There's a selection bias. And given 50% of people were fine, thank you, I cut my estimates of negative prevalence in half, but I don't know what to do with the positive prevalence. I have no idea. Not every, and don't forget, it was only McGill that allowed that ethical fix. Every other site said, oh, how dare you query people who didn't want to be in your study. Only McGill allowed us to do that. So I have no idea.
All right.
This is one of the failures of research, by the way. Research is not really very useful in answering clinical questions because you have to get consent. And you only study people who want to be studied. And if you use routinely collected data, you have terrible data. You don't have very rich data. Or you have rich data on a totally biased sample. It's really difficult to answer clinical questions. But we do our best, and it's replication and repeating. And, you know, Nandini helped us with these decision tree models and kept us focused on fit for purpose, because you can go down that rabbit hole of decision trees. And, you know, are you trying to find the best predictive model so that you can make a decision about an individual patient? No, I'm not trying to do that. I'm trying to identify a portfolio of likely variables that's other people that we can put into test. We have a lifestyle intervention going on now in HIV, going on now, good luck with that, COVID, you know, that is being planned. And our intervention is largely on motivation and goal management training and social network.
Well, thank you very much for that response, Nancy. And I'll just say that, you know, I'm always impressed by Nancy. She will boldly go where no one has gone before, and, you know, force people like me to read about decision trees and random forests, which I'm happy to.
And bagging, we did bag, we did. Yeah, so
thank you. No, it's a very interesting project. And so basically what you've learned is that aging is, successful aging, factors that predict successful aging, it doesn't matter whether you're HIV positive or not. It's really the same social factors that seem to come out as important.
Well, you know, the other studies, you know, quite frankly, I don't know what their answer was. You know, this has always been my voyage in research. Do you have an answer, or do you have the right answer? I am not convinced that any of those studies have the right answer. They just did stuff. You know, here's a model, I got a Y, I got an X, let's put it together in a soup. You know, whatever comes out, comes out. I'm not convinced that that is any kind of an answer. So, you know, that's why it takes me 100 years to write a paper, is because, you know, I have to go down this rabbit hole. And so I think, I can't tell that it's got anything to do with HIV or not, but I was totally shocked by the lack of the poor performance on the SF36. Given I study stroke and hip fracture and multiple sclerosis and Parkinson's, they actually look better than these people. They're better than this group. How does that happen when you don't really have a broken leg or a... So they're not doing that well.
One of the reasons that I think has, so this is a special cohort. It was assembled before the heart era, and their naders were pretty, you know, they were pretty low. That means the probability of them controlling the infection over time was low to begin with.
Yes.
And, you know, over the duration of this illness, and because I work in HIV, it's very evident that they have faced, those ups and downs that happen with therapy over time. So that is in and of itself a predictor of how you control infection over time. And this in addition to the other things that are very characteristic of HIV patients everywhere across the world, not just here in the United States and also in low and middle income countries. I think there is that loss of, self-esteem, stigma, discrimination. So that ties in a lot with the social setup. So, I think the findings are completely in consonant with all the clinical and all the, social findings that we have in the field. So I think you're bang on. I think what would really help if we could assemble a post heart or a post, the new therapies that they have on a younger cohort and apply that, and then see what's happening in a younger cohort and how they define successful aging.
Yes.
How is that panning out in the younger? Because even in the developing world, women are living successfully, when they have access to option B, which is a better cocktail of drugs. So people are, you have a lot of future in this space.
Yeah, no, I'm moving on. Thank you.
I'm just going to...
I'm passing the banner.
I'm just going to ask another question from Kaberi, and her question is, how does the decision tree approach differ from forward selection of variables in a logistic regression model? How do you decide the order of variables in the decision tree?
Well, part of that should be asked by Nandini, because for Nandini, I'm not letting you off the hook. My understanding of the approach is that really the decision tree is much more along that sort of machine learning type thing. It just iteratively goes through and tries to find the item that splits it with the greatest separation. But the most important thing, which you've hit the nail on the head, is you don't decide on the order of the variables. It'll tell you what it is. You've got to get those variables correct, because these models were developed for perfectly measured uncorrelated variables. How do you predict MI? You put in the blood sugar, you put in the hypertension, you put in their cholesterol, you put in their family history, put in their age and their sex, and it comes out. This is a mess. If I use just unthinking, I have items that ask you about energy and fatigue. Well, the first time you run a model, you get energy. The second time you run it, you get fatigue. And then you realize, well, that's stupid. They're measuring the same construct. So we did a lot of analysis of the variables to make sure they were uncorrelated. So we did that pre. Now, Nandini's going to answer about logistic regression and trees.
Okay, I think I just will say, from my point of view, forward selection, as you can see from its very definition, involves selecting a subgroup of variables. Whereas in decision trees, you're not dropping any variables. You're going to split people into categories. And in fact, that's where you have some control. Nancy says she stopped the splitting to ensure there were 30 people in each group. You can split it down to the point where you have one person in each group.
Yes.
And so you're not actually selecting variables. And what Nancy referred to as pruning is, as you can imagine, as the finer and finer the splits, the less reliable that you will be able to replicate those splits in another model. In other words, the less confident you are that that particular pattern can be used to predict successful aging in another setting. So, which is why whether you're going to do it, manually, or whether you're going to allow the computer program to do it, often we make some choices to prune the tree so that it doesn't go down to its lowest possible level.
And then when you run it again, you get another answer. The only thing I'm confident is we ran 1,700 models, and those variables always came out the same time. Because every time, while we were learning, this is what happens. You're learning, you realize I put in an item that had both energy and fatigue. Well, you can't do that. So, we had to make sure that pick the best item.
Right.
So no matter what we did, though, and there's lots of choices of what to do with missing data. There's all sorts of selections for missing data. There's all sorts of selections for all sorts of other things that I don't remember, but Lynn and Nandini helped us with it. Yeah. And it didn't matter really what you did. Those variables always came out.
Yeah, I mean, I'm familiar with this classification and regression trees, which, like Nancy says, was described in the 80s. Yeah. And there you don't get these multiple responses. You've got one data set.
Yeah.
You get that same tree over and again. But Nancy, being Nancy, went and investigated something called random forests,
Yes.
which, as you can see from the name itself, is going to give you some variability in your results.
Yeah.
And it's a bit like bootstrapping. The idea is that it is going to pick different subgroups of your data set and run that tree over and over again, resulting in different results. And I think I think Nancy explains it very well right there. If you do it over and over again and you get some consistent results, then you're more confident that those variables are important.
So what's next, Nancy, in your kitty in this space?
I'm trying to put this into a paper. So anybody that has suggestions is, what in the name of God am I going to do with this paper? And where I might publish it, because it's as I say, I'm convinced that much of what's published in the literature is an answer to a question. It may not be the right answer. And so this needed this whole voyage to convince me that I think that I have as good an answer as we're going to get given the data. So I can't imagine trying to write this up. Part 1, part 2, part 3, part 4. So any suggestions? I formulated for HIV Lancet, and
I think this could be, there are so many cohorts in HIV. This could be applicable to many of these cohorts, and they could use your techniques to figure out what successful aging is in each cohort.
Yeah.
And that
like we have the VAX cohort.
Interesting to collate that data across different cohorts in different parts of the world.
Yes.
Figure out how their patients are doing. It could be a collective measure. It can be used for how effective the therapy has been, and how does it really, because in the light of these 95 targets, UNAIDS targets for HIV elimination, it's extremely important to talk about, even if you're going to get these patients on therapy, are they actually going to live well?
Exactly. And that's the social determinants of health. It isn't just a drug. You can't just rely on a drug to fix that human being. Is that what are the social networks? How can we support people? A lot of our cohort are, were gay men in the early 90s and 80s, where it wasn't, such a common feature, and they lost their social network. They lost their families. They may have lost, a lot of our people have lost partners to AIDS. They're lonely, they're isolated. They're not, the young gay men who are, know how to, get involved in groups. They're in their 60s. And we did a study on loneliness, and we did a qualitative study on loneliness, and we were all crying, because they're telling you these very sad stories about, living alone and not knowing in this day and age how to develop relationships and have friends and partners. And, so we have to do more as a society for our vulnerable people than rely on the healthcare system. The healthcare system is not equipped to deal with this. So it needs a team.
I think this work can actually have a lot of international implications. So whenever your paper gets published, please do share it with me. I'm going to share it with all the networks to look at how it can be applied beyond treatment targets that we always keep bragging about.
Yes. So Heather had an interesting question about why I didn't put the C3Q. Why didn't I put the cognition in the tree? So one of the challenges with trees is the measurement scale. And the two cognitive measures, you see, the thing is you're allowed to be flexible. Like once I have my cells, I can characterize each of those cells. Who are these people that have 95%? What's their age, sex, height, and weight, cognition? One of the challenges with these modeling things is that sticking in a continuous variable is really awkward. The decision trees are really happier when everything is categorical. And I am really allergic, me and Frank Harrell are really allergic to taking a continuous variable and chopping it up into some arbitrary piece. And so we like to treat data as it comes, like vegetables, data should be served raw. And so we had other options. You see, analyses are so flexible, you don't have to have one size fits all. We can still include cognition, but we put it in as a variable to explain successful aging by itself, and then including all the other variables. So it's like over and above. over and above these variables, what is the role of cognition? And what you saw, it's very little. It's neither necessary nor sufficient. And we didn't put it in on the Y side. I didn't put it in a successful aging. I only have 14%. If I added normal cognition, we would have nobody. Because while a lot of them have this sort of sub-functioning, sub-level of cognition that is sort of about the 50% level in this particular cohort, with, obviously with some notable variations. But, and also, what can you do about it? What can I do about somebody's cognition? That, those are people dreaming in Technicolor that some magic drug is going to change your score on a test. It isn't. And how can you prevent cognition? You can't prevent that. You can't put in an activity that's going to say, okay, I'm going to stop smoking. I'm not going to get lung cancer. I'm going to stop smoking and I am going to not get dementia or improve my cognition. In our data set, the only factor that affects cognition is smoking. The only thing. Looked at everything. We have every drug they ever took and every, and it's really the only thing that ever came out was smoking. So I felt that cognition was of interest, but I didn't want it to be part of the Y, and I'm assessing where its role is in the X. So what I think I will do is I will take my successful aging groups, because I'm interested in the people, not the variables, and say, how was their cognition, by the way? So you found that there were people with successful aging whose cognition was very low, and other people was very high. And people with low successful aging, their cognition was just fine, thank you. So I chose to deal with it in a different way. And this is why when you're dealing with a complex outcome, you can't just treat every variable in the same model. They don't all fit in the same model nicely. At least in my opinion and my experience of doing this for quite a while.
Thanks for your answer. That's really
a very good question.
Great. Any more questions? So Elena said that it's a very interesting approach and it can provide a new way of looking at how we do research and who we target.
Yeah. So in my little blurb, what is the question? Don't lose sight of your methods and think your methods are the answer to the question. Because I did the usual no-brainer and did the logistic regression and went, what am I going to do with these variables? And then it was a realization that I'm not interested in variables. I'm interested in people. How do I get the people? And so that made me rethink it. And I think that if you always write your research question and glue it on top of your computer, don't run off in those rabbit holes of modeling and keep sight of what question am I answering? These models are just tools to serve the greater good. They're not the end of they're not there for their own purpose. They're only there to serve the greater good. So write the greater good on your computer to make sure you don't go down that rabbit hole.
Well, we don't have any more questions. I think it's time. Shall we?
I noticed Claudie said yes to Canvas and her SF36. Thank you, Claudie.
Yeah. She said, thanks for making your presentation easy to understand and those who are not well versed in the specific domain.
Like me, I didn't know anything about it, so we're all in the same boat.
Yeah. Thank you.
Right.
Thank you. Thank you, Nancy. Everybody is very impressed with the talk and they are wanting to use it in their spaces. I think that's the best part about
so you can tweet it now.
Yes.
Tweet social determinants of health.
That's true.
Good.
Thank you so much.
Good.